Okay, class, good day. So, this would be the second part of your endocrinology. So, last time we finished with your cortisol, which is a glucocorticoid, if naalala nyo. Siya yung principal glucocorticoid. This time, we will continue class with aldosterone. Now, aldosterone class is the most potent mineralocorticoid. This is an electroregulating hormone. This is a steroid hormone that would help regulate water and electrolytes, especially sodium, potassium, and chloride, as well as blood pressure. Sodium levels class in your serum would depend almost completely on the interplay between aldosterone and your ADH or vasopressin. It acts on renal tubular epithelium to increase retention of sodium and chloride and excretion of potassium and hydrogen. The synthesis of aldosterone class is controlled by the RAAS or the renin angiotensin system. The enzyme here responsible for the synthesis of aldosterone class is your 18 hydroxysteroid dehydrogenase. So, responsible siya class para ma-create si aldosterone. So, ayan siya. So, this is the example class on how aldosterone is very important in maintaining blood pressure. If you notice here, whenever there would be, whenever your brain would send a signal class to create ADH and even aldosterone. So, halimbawa, nagkaroon ng problem with your blood pressure or your kidney function. All of this, all of that problem will cause signals to be sent to the brain, to the adrenal cortex. Now, what happens next is that the brain would secrete the ADH, the adrenal cortex would secrete aldosterone. And lahat sila class, they would go to or they would target the kidney. And sa kidney class, they would perform different function. There would be sodium and water retention, increased blood volume, cardiac output, increased arterial pressure, and so on. So basically, class, the two aldosterone, ADH, even your renin and angiotensin help control sodium, potassium, and chloride retention, and even the blood pressure. Now, what are the disorders related to your aldosterone? We have your primary hyperaldosteronism, also known as your Conn's disease. This is caused by aldosterone secreting adrenal adenoma, elevated plasma aldosterone, and low plasma renin. Distal delivery of sodium is increased because of increased sodium chloride reabsorption in the cortical collecting duct by the action of aldosterone. It also inhibits salt reabsorption in the proximal tubule as the result of volume expansion. So sa Conn's disease class, there is too much aldosterone secretion and usually caused na naman to by another type of tumor, adrenal adenoma. So there would be increase, elevated ang aldosterone nyo. You would have elevated aldosterone but you would have low levels of renin. So increase class ang delivery ng sodium nyo, increase yung reabsorption, increase ang reabsorption ng sodium nyo in the cortical collecting duct. Pakitandaan to ha. In the cortical collecting duct, while another effect here is that aldosterone would inhibit salt reabsorption. So mababa naman ang sodium nyo in the proximal tubule. So kapag may Conn's disease ka, increase ang sodium sa cortical collecting duct. Pero decrease ang sodium naman class sa proximal tubule. So itong mga proximal tubule, collecting duct, nasa kidneys yan. So remember that. That's one sign of having Conn's disease. Increased sodium, again in the collecting ducts, decreased sodium sa proximal tubule. Then we have your secondary hyperaldosteronism. This would occur as a result of excessive production of renin, elevated plasma level of aldosterone and renin. In this condition, hypokalemia occurs in increased distal sodium delivery. Associated disorder are your Liddle syndrome or your pseudo hyperaldosteronism, Bartter syndrome, bumetanide sensitive chloride channel mutation, Gettelman's syndrome or your thiazide sensitive transporter mutation. Then we also have your hypoaldosteronism due to the destruction of the adrenal gland and deficiency of glucocorticoid. It is associated with 21 hydroxylase deficiency. Then, aside from your cortisol, your aldosterone class, we also have weak androgens and adrenal androgens. So these are the precursors for the production of the more potent androgens and estrogens in tissue, produced as byproducts of cortisol synthesis that are regulated by ACTH. Excessive levels of androgens can be confirmed by measuring total and free testosterone and DEAS or your dehydroepiandrosterone sulfate. Now, adrenal medulla class is composed primarily of chromaffin cells that would secrete catecholamines. L-tyrosine is the precursor of catecholamines class. So, ganito yun. In the adrenal medulla, you would find the so-called chromaffin cells. Itong mga chromaffin cells na to class would be the one responsible for secreting catecholamines. And ang precursor bago maging catecholamines class, they are known as L-tyrosine. So si L-tyrosine, this would be converted into your catecholamines. Siya yung precursor. Now, synthesis of medullary hormones class norepinephrine and epinephrine are metabolized by monoamine oxidase and catechol O methyltransferase to form metaneprins and vanil mandelic acid. So, itong norepinephrine nyo class and epinephrine nyo would be acted on by, sige, ito siya, nor ayaw magano. Ayan. Si norepinephrine nyo class and epinephrine, they are converted or they are metabolized. Itong dalawa na to. They are metabolized by two enzymes, yung MAO or monoamine oxidase and yung COMT or your catechol O methyltransferase. Kapag inano nila class, nag-act out sila doon or minanabolize nila, this would form metanephrine and vanil vanillyl mandelic acid. So, pakitandaan yan. So, ito siya class. Conversion by COMT. So, COMT class would convert epinephrine to metanephrine, norepinephrine to normetanephrine, dopamine to methoxytyramine. So, lahat to class, itong tatlo na to is done by COMT. Sa epinephrine, kino-convert siya to metanephrine by COMT. Norepinephrine would be converted to normetanephrine, dopamine to methoxytyramine. All of which can be oxidized to VMA by MAO. So, after nyan, itong tatlong to, pwede siyang maging VMA class or your vanil mandelic acid by the action of the enzyme MAO. So pakitandaan. Now, synthesis of medullary hormones class, the ratio of norepinephrine to epinephrine is 9 is to 1. The hormones are 50% protein bound. So, mas madami si norepinephrine class sa epinephrine. 9 is to 1 yung ratio nila. Now, norepinephrine is also known as your primary amine, produced by the sympathetic ganglia. The highest concentration is found in the brain. MHPG is the major metabolite in CNS. So ito yung MHPG class. It stands for 3-methoxy-4-hydroxyphenyl glycol, usually found in the CNS, especially in the CSF, and even in the urine. Major metabolites class silang dalawa, BMA and MHPG. So, ang meaning nito, itong major metabolites, kapag itong si norepinephrine class na broken down siya, it produces this two. 3-methoxy-4-hydroxyphenyl glycol, which is found in CSF and urine. Kaya siya nakikita sa urine kasi nga, di ba, it's a metabolite. Broken down by product siya class. A broken down product of uh, norepinephrine. Then we also have your epinephrine class. This is also known as your adrenaline or secondary amine. So familiar kayo dito class, ito yung tinatawag nilang flight or fight hormone. This is the most abundant medullary hormone produced from norepinephrine and comes only from the adrenal. Only release if there is a stress. Kaya nga 'di ba pag uh, if you're if you are encountering a fire class, yung nasusunog yung isang location or ano tapos nandun ka sa loob, epinephrine would be released. Kaya yung mga story na ng mga nasunugan, yung story na mag-isang tao lang nabubuhat nila yung refrigerator by themselves. That's an effect of your epinephrine. And strictly release lang siya under stress class. Usually in response in physiological injury, stress, anxiety, and threats. Increases glucose concentration via glycogenolysis. So sa glycogenolysis class, glycogen is broken down. Kaya nga lysis, di ba? Glycogen is broken down to become glucose. Any form of stress that increases cortisol stimulates its production. So kapag under stress ka, 'di ba nga pag stress ka, mataas din ang cortisol mo. And kapag mataas ang cortisol mo, class, pwede ring tumaas or mag-produce ka ng epinephrine. It is best collected from an indwelling catheter since venipuncture may cause levels of catecholamines to rise. So ito yung example nung pag-collect niya, class. Usually, you would ipapasok mo yung catheter through the sexual organ, through the penis or through the vagina and into the urethra to collect the sample. Ang reason kaya hindi ka pwedeng because mag venipuncture, magra-rise yung catecholamines mo. Now, what are the major metabolites of epinephrine? VMA din, class. This is the major 60% of catecholamine metabolite in urine derived largely from norepinephrine. This medication is used in emergencies to treat very serious allergic reactions to insects, sting bites, food, drugs, and other substances. Epinephrine acts quickly to improve breathing, stimulate the heart, raise a dropping blood pressure, reverse hives, and reduce swelling of the face, lips, and throat. Kaya nga, class, yung mga patients that are undergoing or that require resuscitation, i-resuscitate mo siya, bubuhayin mo ulit. Yung ibang, yung nire-require or binibigyan sila ng epinephrine. Epinephrine basically stimulates the heart class and even raise a dropping blood pressure. And napansin nyo rin ba na yung major metabolite nila is always VMA? Then we have your dopamine class. So catecholamine produced in the body by the decarboxylation of 3,4-dihydroxyphenylalanine or the DOPA. Highest concentration in the regions of the brain. This is the major intact catecholamine present in urine. Major metabolite is again homovanillic acid naman. So homovanillic acid this time class. Kanina di ba VMA? This time, homovanillic acid. Then we have your Pheochromocytoma class. This is the tumor of the adrenal medulla or sympathetic ganglia caused by the overproduction of catecholamines, commonly seen in the third to fifth decades of life. Classical spells would involve hypertension, tachycardia, headache, tightness of chest, and even sweating. Screening tests would include plasma metanephrines and normetanephrines by high performance liquid chromatography, usually a four-fold increase. Diagnostic test is a 24-hour urine excretion. Metanephrines and normetanephrines are increased. Patient preparation class avoid caffeine, nicotine, alcohol, and acetaminophen and tricyclic antidepressant for at least 5 days before testing. Pharmacologic tests would include clonidine tests used to differentiate pheochromocytoma, which is not suppressed, to neurogenic hypertension, 50% decrease in catecholamine levels, or those individuals with borderline elevations in urinary tests. The clonidine 0.3 milligram oral suppression test is used only if the plasma catecholamines are greater than 1,000 picogram per ml or 5.9 nanomoles per liter. Then another test class is the glucagon stimulation test, highly suggestive of pheochromocytoma, used for individuals with normal blood pressure and when catecholamines are only moderately elevated, usually threefold increase class. Then after pheochromocytoma, another disorder is your neuroblastoma. This is a fatal malignant condition in children resulting to excessive production of norepinephrine. Positive result is high urinary excretion of HVA or your VMA or both and even dopamine. Method specimen class is 24-hour urine and blood. Patient preparation is overnight fasting. Avoid smoking or drinking coffee at least 4 hours prior to collection. Increase plasma catecholamines. The patient is placed in reclining position in quiet environment and heparin lock is inserted intravenously. After 20 to 30 minutes, blood is collected in a pre-chilled ETTA. So, another consideration dito, class, is yung position, body position, and samples must be collected after 30 minutes in a stable position. Decrease ang values niya when in supine position. Methods used class are your chromatography, either high performance liquid chromatography or GCMS for VMA and metanephrine. Radioimmunoassay could also be used. This is a sensitive screening test for total plasma catecholamines, usually greater than 2,000 picograms per ml of plasma catecholamine. Diagnostic for pheochromocytoma. Specimen consideration, catheterization class. This is the preferred method of blood collection to eliminate anxiety of venipuncture. Parang ako class between the two, between having a catheter inserted to me. Mas gusto ko yung venipuncture. Kasi pag catheter, para mas magkaka-anxiety pa ako. Then another consideration, urine preservation class. You have to consider processing the urine immediately because they are rapidly oxidized at higher pH. So kapag alkaline yung urine nyo, mas decrease yung catecholamines and metabolites. 24-hour urine creatinine test. Urine creatinine is needed to validate the completeness of the urine collection. To prevent catecholamine oxidation, blood samples must be transported on ice. Now let's go to another gland class here, parathyroid gland. This is the region of the thyroid gland, sometimes within the thyroid gland. 2, 4, and 8, but most people has four lobes of the parathyroid. Smallest endocrine gland in the body. Secretes your PTH, which is a hypercalcemic hormone. The thing you need to remember, class, about PTH is that they are related siya sa calcium. Laging magka-relate yan, dalawang yan. Now, responsible for calcium homeostasis. So, balance of calcium levels. So, it maintains calcium and phosphate under the influence of two polypeptide hormone, PTH and calcitonin. So, na-maintain yung calcium levels, class, by these two, PTH and calcitonin. Now, what is the role of your PTH, class? Regulates blood calcium, preventing the loss of calcium hypocalcemia. Preserves calcium and phosphate within a normal range. Promote bone resorption. Release calcium into the bloodstream. It increases renal reabsorption of calcium. It stimulates conversion of inactive vitamin D to activated vitamin D3. Indirectly stimulates intestinal absorption of calcium. As calcium level increase, PTH secretion is suppressed, allowing urinary loss of calcium and calcium to remain in the bone. If calcium levels decrease, PTH is released. Now, calcium is the most abundant mineral in the body, enables our blood to clot, our muscles to contract, and our heart to beat. It's responsible for strong bones and team up with phosphates. Sorry, class, phosphates. Yun. So, partner din ng calcium at phosphates. Now, too much calcium in your body, class, or in your blood could cause the following. It can cause the creation or the weakening of your bones, kidney stones, class. Most of your kidney stones, pakitandaan, are made up of calcium. And it could interfere with how your heart and your brain works. So pag masyadong madaming calcium, class, it can lead to problems in the heart and the brain. Now, the kidneys, class, they would remove excess calcium in your blood, um, causing it to work harder, filtering it. This can cause excessive thirst and frequent urination. So kapag masyadong madami kang calcium sa blood mo, class, ang kidneys mo, they would compensate by increasing thirst and increase urination. In chronic kidney disease, high serum phosphate concentration is associated with CVD or cardiovascular disease and deterioration in renal function. Digestive system, class, hypercalcemia can cause stomach upset, nausea, vomiting, and constipation. Bones and muscles, class, in most cases, excess calcium in your blood was leached from your bones, weakening them. This can cause bone pain, muscle weakness, and even depression. For the brain, class, too much calcium naman can interfere with your brain, resulting in confusion, lethargy, and fatigue, causing also depression. Heart, class, this would occur rarely but too much calcium can interfere with the function, causing palpitation and fainting. There could also be cardiac arrhythmia and other heart problems. Now, what are the disorders of your PTH? We have your hyperparathyroidism class. The first one under hyperparathyroidism is your primary hyperparathyroidism, the most common cause of hypercalcemia due to the presence of a functioning parathyroid adenoma. It is accompanied by phosphaturia. If it goes undetected, severe demineralization may occur. Ostitis fibrosa cystica. This is a skeletal disorder caused by a surplus of PTH from overactive PTH gland. Lab results of your primary hyperthyroidism would show increased PTH, increased ionized calcium. While for secondary hyperparathyroidism, this is usually this would usually occur class if there is a decreased serum calcium. Parathyroid hyperplasia is the diffuse enlargement of the parathyroid gland. Causes would be vitamin D deficiency and chronic renal failure. Patients would develop severe bone disease. Lab result would show increased PTH, decreased ionized calcium. Then we have your tertiary hyperparathyroidism. Meron tong ano class hyperparathyroidism na ano lang na typo lang. This would occur with secondary hyperparathyroidism. The phosphate levels are normal to high. Calcium phosphates would precipitate in soft tissues. Then we have your hypoparathyroidism. This is due to accidental injury to the parathyroid gland, usually during surgery or any possible post-surgical causes. Other causes would include autoimmune parathyroid destruction. Individuals are unable to maintain calcium concentration in blood without calcium supplementation. Low PTH class causes elevated bicarbonate reabsorption, leading to a state of alkalosis. Calcium levels of less than 6 milligram per DL, there would be laryngeal stridor and tonic-clonic seizure. Calcium levels of less than 8 milligram per DL can lead to tetany and altered neuromuscular activity. We have the Vostek sign and Trousseau sign. Tetanic seizure is a medical sign consisting of the involuntary contraction of muscles. So ito yung dalawang sign class kapag may hypocalcemia ka, yung Vostek sign and Trousseau. So kapag Vostex, there would be contraction of facial muscle in response to tapping the facial nerve. So kapag tinap mo yung facial nerve class, there would be contraction of your facial muscle. Kapag naman Trousseau sign, there would be carpal spasm occurring after occlusion of the brachial artery with a BP cuff with a pressure of 20 millimeter of mercury above systolic BP for 3 to 5 minutes. So there would be carpal spasm near the brachial artery class. Now let's go to the reproductive hormones class. So synthesis and transport of hormones, the testes and ovaries would produce sex steroids such as androgens and estrogens form cholesterol. This is from cholesterol. The ovary converts testosterone to estradiol and androstenedione. Androstenedione class is the endogenous weak androgen to estrone. So si testosterone class, yung ovary niya, pakitandaan. Ovary converts testosterone to estradiol and androstenedione. And this is further converted class to estrone. Peripheral tissues, including those targeted by androgens, would reduce testosterone to dihydrotestosterone, hydroxylate estradiol to estriol, and converts adrenal androgens to testosterone and androgens to estrone and estradiol. So, what are the major transport protein? We have your SHBG, or the sex hormone binding globulin. You also have the corticosteroid binding globulin. And the third one would be albumin. Now, your SHBG would transport androgens and estrogen. Pakitandaan to, class. SHBG ang tinatransport niya, androgens and estrogen. CBG, or your corticosteroid binding globulin, delivers progesterone and glucocorticoids. About 1 to 2% of the sex steroids class are free or unbound, while the remaining are bound to proteins. Sex hormone binding globulin, corticosteroid binding globulin, and albumin class. So, onting-onti lang class, pakitandaan to, only around 1 to 2% are free. The remaining 98 to 99% class are usually attached sa tatlong to. Only the free fraction of the hormone is biologically active because only the free form can diffuse into the vascular system and interact with target cell. Now let's start with the first one, yung testosterone class. This is the principal androgen hormone in the blood. This is the most potent male androgen. It is synthesized by the Leydig cells of the testis of the male, also derived from progesterone. It is controlled primarily by follicle stimulating hormone and luteinizing hormone, responsible for the growth and development of the reproductive system, the prostate, and the external genitalia. Physiological factors levels demonstrate a circadian pattern. So nagpipeak siya class ng 8 a.m. and the lowest would be at 8 p.m. There is a gradual reduction in testosterone after 30. So pagdating mo ng 30 or after 30, there would be a reduction. So mababa na yung testosterone nyo class with an average decline of 110 nanograms per deciliter every decade. Now, obesity class can cause decreased testosterone. After age 50, men experience a decrease in secretion rate and concentration of testosterone, and women have an increase in pituitary gonadotropins. Tests of male infertility would be semen analysis, testosterone, FSH, and LH. So, aside from seminalysis class, pwede din kayo magpa-test ng testosterone nyo, FSH, and LH. So, the reference value of your testosterone class is 3.9 to 7.9 nanograms per ml. Transport protein would include albumin and SHBG. The concentration of binding protein determines the level of total testosterone, but not the free testosterone level during lab estimation. Now, what are the types of testicular infertility or hypogonadism? So, we have your pre-testicular infertility, also known as the secondary hypogonadism. This is due to hypothalamic or pituitary lesion. There would be normal or decreased levels of testosterone, FSH, and LH. Kapag naman primary hypogonadism, this can be congenital class, usually seen in cryptorchidism, Klinefelter syndrome, and 5-alpha reductase deficiency. For acquired naman class, seen in varisol, tumor, and orchitis. Then we have your post-testicular infertility. It is due to disorders of sperm transport and function. There would be normal testosterone, normal FSH, normal LH in the blood. So, ang problema dyan, class, is yung transport ng sperm nyo. Basically, the sperm itself is the problem. Now, what are the other disorders of sexual development? We have your testicular feminization syndrome. Most severe form if androgen resistance syndrome, resulting in lack of testosterone action in the target tissue. The physical development pursues in female phenotype with fully developed breasts and female distribution of fat and hair. There is utility or no response of exogenous testosterone. Lab levels would show normal testosterone, elevated FSH and LH levels. Then we have your Sertoli cell only syndrome. So Sertoli cell only syndrome class, there is the lack of germ cells. The primary sign of Sertoli cell only syndrome is a lack of production of sperm cells. Testicular biopsy is the only procedure to confirm this diagnosis. Then we have your Kalman syndrome. This is a result of an inherited X-linked recessive trait, hypogonadism during puberty. Associated defects would include anosmia, inability to smell, and midline defects such as cleft palate and lip problems. Then we have your DEA or your dehydroepiandrosterone. This is the principal androgen formed by adrenal cortex. It is considered as a weak androgen, primarily derived from the adrenal gland class. Valuable assessment for adrenal cortical function. Then the third one is estrogen, arises through structural alteration of the testosterone molecule. So galing siya sa testosterone class. It is not produced by the ovaries after menopause. Promotes breast development, maturation of the external genitalia, deposition of body fat, and termination of linear growth. Secondary sexual characteristics in the female. In conjunction with progesterone class, they function in uterine growth and regulation of menstrual cycle and maintenance of pregnancy. Deficiency would lead to irregular and incomplete development of the endometrium. Kaya nga yung iba na lacking estrogen class, they have a disorder known as endometriosis. Usually naman pag endometriosis, masyadong madami namang estrogen class. Kaya one problem ng mga transgender, if ever they could have severe problems with some of their organs class, reproductive organs nila. So a precursor of your estrogen is the acetate, cholesterol, progesterone, and testosterone. So acetate muna siya class, then cholesterol, then progesterone, then testosterone. After testosterone, pwede na siya maging estrogen. So pakitandaan yan. Now, what are the three forms of estrogen class? We have your estron or your E1. Estron is the most abundant estrogen in postmenopausal women. Then we have your E2 or your estradiol. This is the most potent estrogen secreted by the ovary, considered as the major estrogen. Low levels in the menopausal stage. Synthesized from testosterone, then diffuses out of the thecal cells of the ovaries and female. Precursor siya ng E1 or your estrone and E3. Used to assess ovarian function, has a negative feedback for FSH class. So, if it's a negative feedback class for FSH, meaning yan, ini-stop niya. Pag too much, stops too much creation of FSH. Transport proteins, albumin 60% and SHBG 38%. Then your E3 is also known as your estriol metabolite of E2 or your estradiol. Estrogen found in maternal urine. This is the major estrogen secreted by the placenta during pregnancy. Formation in a pregnant woman is dependent on fetal and placental function. Used to assess the fetoplacental unit, post-date gestations, and intrauterine retardation. Promotes uteroplacental blood flow as potently as other estrogens. Uses a marker for Down syndrome together with AFP and HCG. Preferred specimen is plasma. Then we have progesterone naman class. Progesterone is mainly produced by the granulus or the lutein cells of the corpus luteum in the female. Prime secretory product of the ovary. Dominant hormone responsible for the luteal phase cycle among female. Single best hormone to determine whether ovulation has occurred. Evaluation of fertility in females. So progesterone naman class is used for the identification of fertility sa females. Kung sa lalaki, testosterone, sa babae naman, progesterone. Serves to prepare the uterus for pregnancy and breast for lactation. Deficiency, failure of implantation of embryo. So, pwedeng hindi kumapit class. Hindi kumapit yung implant na yon sa embryo of the embryo. Now, the menstrual cycle is made up of four phases. Each phase would serve a different function. Menstruation is when you have your period, and this is your body shedding your uterine lining from the previous cycle in the absence of pregnancy. The follicular phase, which overlaps with menstruation on the first few days, is when follicles grow. One follicle will generally become larger than the rest and release a mature egg. This signals the end of the follicular phase. Ovulation is when the mature egg is released. The luteal phase begins as the egg starts traveling down the fallopian tube. This phase ends when your next period would begin. Once the follicle has released its egg, the egg travels down the fallopian tube where it may come in contact with sperm and be fertilized. The follicle itself then changes. The empty sac closes off, turns yellow, and transforms into a new structure called the corpus luteum. The corpus luteum would release progesterone and some estrogen. Progesterone thickens the lining of your uterus so that a fertilized egg can implant. So yun yung reason class kaya kumakapal yung lining ng mga babae ng kanilang is that so that the fertilized egg class can be attached or implanted. Blood vessels grow inside the lining and these vessels will supply oxygen and nutrients to the developing embryo. Ngayon, in case na hindi ka mabuntis or hindi mabuntis yung babae, yung mga thick linings na yan, it would start to shed off. And this would occur via menstruation. And then after nun, papalitan na naman yung class hanggang sa makadetect yung body ng babae na buntis sila. So if you get pregnant, your body would also start to produce human gonadotropin. This hormone would maintain the corpus luteum. HCG enables the corpus luteum to keep producing progesterone. So pakitandaan to klasa, yung human chorionic gonadotropin nyo is the one that maintains corpus luteum to keep producing progesterone until the 10th week of pregnancy. Then after the 10th week, si placenta na ang mag-take over ng progesterone production. So that basically ends the entire endocrinology. Thank you.